when practicing at a distant location across the nation or across the world. One mentoring interaction, however, is not enough, not for proficiency. This can only be with substantial practice. And a good mentor relationship requires the mentor and student to be together on multiple occasions. So how can this happen? Telementoring. Let me make one fast, important distinction. Telemedicine and telementoring are not the same thing. Telemedicine is the practice of medicine. It's using virtual reality where a physician performs patient care from a remote site. Telementoring is the teaching of medicine from a remote site. Telementoring occurs when an experienced surgeon guides and mentors a learning surgeon at the learning surgeon's distant location. And ladies and gentlemen, telementoring really works. The literature is replete with anecdotal, no question, studies showing telementoring is a big success anywhere in the world it's been tried. For example, right here in India, in 2006, a doctor called P.V. Pradip successfully performed telementoring in endocrine surgery from 2,500 kilometers away. The pragmatic aspects of telementoring are straightforward because the equipment and necessary bandwidth are currently available and in use worldwide. And I'm going to fly through the next few slides because of time constraints. But on the technical side, there are many companies that make equipment that are suitable for telementoring, like Cisco Telepresence and more. But I'm very fond of InTouch Health, that has worked with stores on one piece of equipment. And I want a disclaimer here. I have absolutely no financial relationship with this company. I've just worked with them, and I think they're terrific. So very quickly, this is the InTouch Health stores. It hangs over the table or can be pushed around in the cart. Next, the next one is controlled by a laptop speed. It's remotely controlled from thousands of miles away across the world. The Army has been using it for years. They have a new device now called RP Vita, which not only can be remotely controlled, but it can control itself. It can be programmed to go from the ER to the OR and up to X-ray, picking up results, running around the hospital all on its own, and then can stand by in the OR for surgical telementoring. InTouch, by the way, also makes a thing called RP Vantage, in case you were worried about open procedures. They have one that will work beautifully with that. And I want you to see the operative site for a minute that it can provide. Isn't that beautiful? You're just right there. So I'd like to take 1.5 minutes of my 12 and show you a video that I think defines telementoring. It's a picture of a doctor in Atlanta teaching two fellows from Argentina in a wet lab or experimental lab in the south of France. Please.
So happy to see you, Dan, Professor Smith. So you are just for the first time coming in our experimental lab. Thank you to be the telementor today. And we are going to join the table of two surgeons from Venezuela. So you come with me, and Dr. Stefano is going to show you the way.
Very good, thank you.
Professor Smith, I want to introduce you two trainees from Venezuela, and they are just waiting. All the troca are put in, and they are waiting all your advice.
Like this, I think?
Uh-huh. Now, do you have where's the other limb of your intestine?
Right here.
Now you can lay the two sides of the bowel close to each other to see where the best place to make the enterotomies for the stapler would be.
I'll open this side, okay?
Yep, yes.
You think it's good right here?
You might try to get a little more anti-mesenteric.
All right. Stapler.
So hold up all three sutures and then run the stapler underneath, close it, and fire it. Okay, now the assistant lets go.
Can I close it?
Yeah, close it. Over here too, so you can That was very nice.
You are permanent invited in our experimental lab. And
Thank you.
Goodbye and thank you very much.
Okay, Jack, thank you.
That is an example of telementoring. Now, how do we address the whole problem? As a practical solution, we suggest the following. Medical schools, at least these are the American medical schools, and medical schools everywhere with top academic credentials. Medical schools and their academic teaching hospitals are the foundation of physician education. It is the men and women educators of the residency and fellowship programs who share their knowledge and experience to train our physicians. These faculties at the institutions should be permitted to help maintain and enhance their student skills after they go into practice. And we recommend academic telementors who can follow a fellow or resident in their new jobs. So former residents no longer will have the benefit. They'll have the benefit of their teacher's presence and no longer will feel home alone. Telementoring will give them an opportunity to have the professor be with them during any challenging or new operation for which they feel lacking in confidence. And I can tell you that after our review, we have found many fellows and residents who have failed to perform safely in their first year of practice when operating alone. Okay. Telementoring will thus create a transition to practice, preventing patient injury and giving patients the opportunity for safer and continued learning curve. We announced our first World Specialty Society study using the FAME template. We gave some money to SAGES, and they are going to be teaching telementoring to bariatric surgeons. We are also going to be working with the Thoracic Surgery Foundation to teach cardiac surgeons how to fix mitral valves instead of repairing them. We intend to we're opening a national center for telementoring. It's a nationwide project founded by our FAME project. We'll draw together the U.S. teaching hospitals and send invitations to 168 academic medical centers and thousands of academic physicians offering to provide telementoring and counseling to the nation's U.S. practitioners. On the didactic side, there'll be a whiteboard showing procedures from many hospitals across not only the nation, but perhaps the world. Imagine a weekly schedule of procedures in every specialty. For example, Whipple's are being shown today at MGH and Duke, Imperial, Oxford at London, and maybe at Ames and Apollo in India. Okay, online grand rounds are currently being provided by many institutions. The model prevents a significant amount of physician error and patient injury, improves outcome, and can be part of the future of lifelong learning. Okay, we also hope to provide eventually a global telementoring network. AMF, in celebration of our Silver Jubilee, has decided to develop this, utilizing centers in India and Europe and in Asia and Australia and beyond. In today's world, when an American has a problem with his computer, he is often referred to India for help. The Global Telemetry Network and Fair and Logical Reciprocity, a doctor in India who wants help performing a new procedure with his computer, will be able to call upon an American doctor for help. The successful implementation of this will reduce problems in healthcare. Telementoring certainly is the best way to provide doctors into areas of underdeveloped countries. And finally, although I focus today primarily on proceduralists, academic telementoring can improve skills of physician in every specialty in every country. The way to begin is with trusted teachers whose hearts are best described in the word of Chaucer, "In gladly would he learn and gladly teach." Thank you.
Thank you, Professor Evelyn. I'm extremely sorry, I have to cut short these sessions because part of the reason is the Chief Minister's security has requested the stage. But nevertheless, we will still make sure that we transfer some of the speaker's message to us. So may I now request Mr. Gautam Kumar Sahaji from Kolkata, and he will be speaking to us about promoting health awareness through web-enabled concept maps-based healthcare knowledge representation and dissemination. Professor. He is from the research and development work on computer science and engineering, and he's with the DRDO and serves in Bangalore as a computer scientist. And presently he's with the Center for Development of Advanced Computing at Calcutta, India.
Good morning, everybody, and let me thanks to organizing committee for inviting me. And I am very pleased to, I am honored to come here and see the objective behind this work. See, whenever you want to have some information on internet, suppose you want lung cancer, then you put in Google search that lung cancer, then you will find hundreds of website pages are coming. So how long will you read through all those pages to get, suppose, 5 lines of information that you need? So my topic will cover some knowledge representation, concept map, semantic network. Then we'll give guidelines, and then we have developed a healthcare knowledge system. It is about from 10,000 pages of medical books, then web content, medical journals. It has been transformed into only 350 pages of concept maps. So it is like a knowledge capsule, because in our busy life, you won't find, common people won't find much time to read